Health and Human Services Committee will come to order. We do have a quorum. Representative Albright moves approval of the minutes from March 29th, 2018. All those in favor of approval of the minutes, please say aye. Aye. Those opposed, no. Minutes are adopted. First bill up on the calendar today, I believe we have 3 bills today, would be Representative Bennett's House File 4198. I will move House File 4198 be laid over. The bill is before us. Representative Bennett, welcome back to the committee.
Thank you, Mr. Chair. It's always good to be back to your committee. I love your sweatshirt.
Thanks.
Very nice. Well, thank you, committee members, for having me here to present this bill, which I think is an awesome bill. We all know how important it is for mental health access for children, especially, try to catch issues early on. And this bill actually increases access to mental health services to students through telemedicine. And I'm sure this committee is familiar with the already successful school-linked mental health program, which started in, I believe, 2007. And then back in 2015, we, as a legislature, approved telemedicine. And this is combining both of those issues to help bring more equitable access for our students with mental health. And I'm going to actually turn this over to Grace in just a minute here, but I just want to add one thing. I have spoken to some of the superintendents in my district. If you don't know, I'm from more of a rural area. We have a lot of smaller schools. We have a real shortage in mental health providers in our area. And everyone, all the superintendents that I spoke to were excited about this because they said this is a way where we can actually utilize that school-linked mental health via telemedicine. Otherwise, parents are having to travel to Mankato or Rochester, and it's just a long way. And so mental health access is just not happening in a lot of cases. So I know your time is short. Mr. Chair, if I could turn this over to Grace Kelleher.
Welcome to the committee, Ms. Kelleher. Please introduce yourself and proceed.
Thank you, Mr. Chairman and members. My name is Grace Kelleher, and I represent the Minnesota School Boards Association. We represent every locally elected school board member in the state, and I am here to strongly support Representative Bill House File 4198. MSBA believes the world has fundamentally changed since the school shooting in Parkland, Florida. As elected school board members around the state have looked at their present school funding streams and student needs that need to be addressed, 3 priorities became apparent: expanding the safe school levy, long-term facility maintenance, and funding for mental health services going forward. And we're asking you support this bill. MSBA believes this bill, which is a present pilot program, could lead to a model to replicate, implement, and ensure equitable access to telemental health services to students across the state. Under this model, students can access support in an environment that is familiar to them, with a delivery model that accommodates the needs of students. Cost under this bill for school districts could be computers with screens, cameras, secure internet connections, private physical space, age-appropriate accommodations, an administrator or a sponsor. With this, we ask that you support Representative Bennett's bill and support school districts in bringing this equity across the state. Thank you, Mr. Chairman.
Thank you for your testimony, Ms. Kelleher. Is there anyone in the audience who would like to testify on this bill? Seeing none, we'll close the testimony portion and open it up to member questions. Other questions? Representative Liebling.
Thank you, Mr. Chair, and thank you, Representative Bennett. I've been a big supporter of school mental health grants, and I think we all have, and heard some great stories from my own district about the success of that, and I think it's a wonderful model. But the question I have is, does the current school-linked mental health grant allow telemedicine to be used, or is this a new thing that's not currently permitted?
Mr. Chair and
Representative
Representative Liebling. A good question, and to my knowledge, it is allowed, and actually it is used in some schools, but there are a number of schools that just do not have the infrastructure right now to be able to do this, especially in rural Minnesota. And this grant would pinpoint those schools and allow them to apply for grant money to get set up for this, so they could get their, like was mentioned, the secure internet, the computers needed, and that type of thing. So this is basically helping widen that availability to more schools than are able to use it right now. But it is currently, from what I've spoken to other people, and I believe Matt Burdick from the Department of Health is here too, and he might be able to shed some more light on that. But it is available. It's just making it more access for more schools.
Yeah, Mr. Chair.
Representative Liebling.
Thank you, Mr. Chair. Thanks, Representative Bennett. And I just, I think we have the same goal in mind here. I just wonder if doing this special pilot thing is the best way to do that. If, for what you're talking about, wouldn't it be better just to find out why some of those jurisdictions haven't been able to access the money and then let them decide whether they want to use it for telemedicine or not? I mean, why are you not taking that approach?
Sure.
Representative Bennett.
Thank you, Mr. Chair. And actually, Representative Liebling, you had the perfect idea, which is where we want to bring this. So my thought here, we're not amending this in this committee, is to actually take off the pilot part and just make it appropriation statewide for any school district that is in need of building or getting that infrastructure that they could access this, and it wouldn't be a pilot. It would just be a chunk of money available statewide to allow that access for school districts that want to do that if they choose. And if they don't choose, they don't need to.
So, Mr. Chair.
Representative Liebling.
Thank you, Mr. Chair. So, Representative Bennett, is there, you mentioned, I think, computers and screens and that stuff, but those are things that people use for lots of other purposes, too. And is there something special about the equipment that you need to do this? Is it like a special secure connection or something unusual that the schools wouldn't, assuming they were fully supplied with the technical equipment they need just for their regular operations, is there something special they need to do this telemedicine piece?
Representative Bennett.
Mr. Chair, thank you, Representative Liebling. There is a special connection. You can't just use like a regular Skype or that type of thing. And I don't know the technical details, but it is a specialized secure connection.
So, Mr. Chair.
Representative Liebling.
Thank you, Mr. Chair. And so it's a connection, but not necessarily equipment that you need? I mean, I just,
Yeah.
Yeah, I mean, you mentioned, buying computers and so on, and I just want to make sure that the funds are actually going, that they'd actually be required to go toward the purpose that we're all wanting to put them toward.
Excuse me.
Ms. Kelleher.
Chair and Representative Liebling, Rochester is an excellent model. It's one we'd like to see around the state. And I think I would start with the space. It needs to be private and off to the side. It can't be a computer lab, and you can't be moving the computer over. It's got to have a screen big enough to have an interaction with someone if you're not, in fact, there. And since we do have good school models who use those kinds of things and they've been effective, we really think that might be the best place to put the dollars so we can replicate that program, hopefully statewide.
So, Mr. Chair, and just finally to wrap up, well, thank you for that. And so with what you just said, it's clear it probably shouldn't be a pilot because we already know people are using it. We already apparently know that there's some efficacy to that. So, that does make a lot of sense. Thank you.
Thank you. Further questions? Representative Bennett, I just had one that, one of the things that we were asking about this was moving through in the last term, and in the budget cycle was just how are we rolling this out? It's a great idea. The kids can kind of access it in the school, and it can be kind of low profile, and it's not an embarrassing thing or anything like that. But if they can but they think that they said more than half of the districts, but less than half of the students were covered under the money that we put forward last year. Would this, and a lot of that was little tiny schools in rural districts are harder to get at because of the professional. Would this help get a greater percentage of the students? And then also, would the kids still access this in the same way, kind of the same low profile way right in the school itself?
Mr. Chair, and good questions. And yes, it would be that same kind of idea of low-profile access within the schools so we can get these kids the help that they need in a situation where they feel comfortable. And your other question about would this help bring more availability to our smaller schools, I think you asked that. And that is where the superintendents in my area, and I actually spoke to those in the smaller schools, Alden and Glenville, and some of those schools that just do not have this capability right now or this access. They're excited about it. They would like to use something like this to get going and get some access for their students.
Great. Other questions? Representative Murphy.
Thanks, Mr. Chair, and thanks, Representative Bennett. Just a couple of questions. When I think about telehealth and connecting to the healthcare delivery system, for me, it articulates a solution for distance and for specialty so that we are able to deliver high specialized care to people who live all over the state, not requiring people to come to the specialty care, but to have the care delivered. That makes sense to me, but we know in Minnesota and across the state that we have a shortage of especially mental health care providers. So have you thought through the fact that we have a finite number of providers and we're just going to be trying to extend that finite resource more? There's a finite nature to that as well. Have you thought, or has SBA thought through the limitation of this just because we do have a finite number of providers at this point?
Ms. Kelleher.
Thank you, Mr. Chairman. Representative Murphy, you bring a good point to bear. You know, it's very hard to project that going forward. Certainly for those districts that really want to go forward, and we've really heard as part of this whole safe school piece, that this mental health piece is huge in schools. And as you get outstate, as you know, you correctly focused on, there's a very limited number of providers. And I think there's sort of people who are natural go-getters in school districts who will be out doing this as soon as the money's available. And then there's those that would sit back and watch for a year or two. And I think it's up to the universities and state universities to really start to turn out more professionals in these areas and in rural areas where we can encourage more growth, because healthcare in outstate Minnesota is a huge deal. And this is just one piece. But clearly, if we can get kids before they hit the point of no return, it's an asset to do. And we believe we can reach more than we are not right now.
And Mr. Chair, thank you for that. And I think that's helpful, and I'm grateful that we're talking about this in the context of safe schools and the health of our students. I do think that's important. As we talk this through as a pilot or removing the pilot language, we're not at this point adding additional funding to the pool of money. Is that accurate at this point? This proposal doesn't look like it's adding any additional funding.
Representative Bennett.
Mr. Chair, thank you, and Representative Murphy. I believe we're just kind of leaving that open to what you all decide. It might be nice to add a little bit of extra for it, but I also know that funds could be tight. So just making this available now, seeing how much use and how much desire there is from school districts and applying. And then after we analyze that for a year and next year look at it, and if there's a big lineup, then we should appropriate more money. So that's flexible at this point.
And Mr. Chair, thank you. I'm almost done. I think that when I think about students in a school and recognizing that someone may be looking and needing some help, this may be one method. But is there a backup plan if, sitting before a screen in a secure and private place in the school and talking to a counselor doesn't meet the needs of that student? For some, that is not going to be a relational way to actually address the problem. And especially in mental health, I think a trusted relationship with your provider is critical. So is there, in addition to this, other methods that you are contemplating, school nurses, school counselors, to make sure that there are adequate resources in our schools to make sure they're safe and our kids are safe?
Mr.
Ms.
Chairman,
Kelleher.
I'd love to answer that one. To be honest, Representative Murphy, we need all those people. We are trailing in school counselors, school nurses are critical, and all those became much more apparent after Parkland. And I think Minnesota really shifted and where we were at as a state to now say that we need those support providers. But there's still a limited nature of those available. So it's going to be very challenging as we go forward, and this was a start to try and get there. But clearly, it may not always be the same type of help, or do we bring someone in for a day or two? Each child is so individual. I think it's really difficult to say, and including flexibility in this language for us to approach it, we'd really appreciate.
Thank you, Mr. Chair.
All right, no further questions. Last word, Representative Bennett.
Well, Mr. Chair, I know that you have a big agenda, so I'll just say thank you again for hearing this bill, and hopefully you can take a look at this as you're moving on.
Always good to see you. And with that, 4198 is laid over. Thank you, Representative Bennett. Next up, we have House File 3133, Representative Koznick. Representative Koznick, welcome to the committee. I will move that House File 3133 be laid over. We have the bill before us. I understand there's an A2 amendment, which is an author's amendment. I will move the A2 amendment. Representative Koznick, please describe the bill and the amendment in any way that you'd like, and we will adopt that.
Thank you, Mr. Chair and committee members. What the bill does is it was intended to provide a grant program for vulnerable youth, age 13, 14, and 15-year-old, for a variety of services that are listed in the bill. But you might kind of wonder why a suburban representative would be interested in carrying this bill. And I have done a little bit of work on the governor's Young Women's Initiative. Today is my daughter's 12th birthday, and I have a younger daughter, and so it kind of touches at home a little bit. But more importantly, I had a constituent last summer helped host a sex trafficking seminar just outside my district, so I went to kind of support that and learn a little bit about it, and I was a little shocked. I was actually kind of naive. I thought, why is a suburban district, why is this much of an issue? Why would we care? And one of the people at that seminar testified or gave a presentation on how she became a sex trafficking victim. She was a bright student from kind of a smaller outside the metro town. Her dad was a pastor. She got good grades. She earned a full-ride scholarship to one of the private universities here in St. Paul on the ROTC scholarship. And she became a victim of sex trafficking. She ended up having a relationship with a boyfriend that took advantage of her and got her into a bad lifestyle. And it made me think that, if it can happen to somebody with, comes from a faith background, a good education, a family of somewhat means, that this is important to, out of my naiveness, it's not just the urban type of an issue. And so I was a little embarrassed to admit that, but I was glad to learn that. And so what I did subsequently was I was invited to take a tour of one of the Tubman centers, and one of my presenter here is Jennifer Polzine. She's the CEO at Tubman. And we were talking about the services that they provide, and one of the gaps is for vulnerable youth that are 13, 14, and 15-year-olds, and they have a license currently to provide services for younger people, but not that young. And so what the amendment does is conforms to the bill that's traveling in the Senate, so that this bill will conform to their language on there, and I'll let Ms. Polzine describe the rest of the bill and the amendment.
Welcome to the committee, Ms. Polzine. Please introduce yourself and proceed.
Thank you. Good afternoon, Mr. Chair, members of the committee. My name is Jennifer Polzine, and I'm the CEO at Tubman, a nonprofit organization with over 40 years of experience serving people of all ages, genders, and cultural backgrounds who've experienced trauma, including relationship violence, sexual exploitation, addiction, and mental health challenges. We serve about 25,000 people each year across the metro region and surrounding counties. HF 3133, the Vulnerable Youth Bill, was originally heard in the House HHS Reform Committee last month, and then when heard in the Senate Human Services Reform Committee, it was on the condition that the bill be amended to be revenue neutral, thereby removing the grant program and appropriations. So we are now focusing on the policy change suggested, the variance regarding ages of youth to be served, in order to improve access for our most vulnerable youth, the young people aged 13 to 17 who are being exploited and trafficked or who are at risk of becoming so. As you know, the Safe Harbor Law was enacted to protect youth 13 to 14, and not coincidentally, the age that youth are most often first recruited for exploitation is 12 or 13. The primary issue has been that while programs like ours all across the state can request a variance to serve youth below the age of 16, it can sometimes take several weeks to do that and to hear back. During that time, the youth are left on the street to be further exploited and assaulted. Staff from the licensing division of DHS originally voiced concerns that the blanket variance proposed would loosen oversight too much. But committee members, particularly Committee Chair Senator Abler, encouraged DHS to talk with us and listen to the expertise and experience of service providers like Tubman. We've worked with DHS to come to an agreement on this amendment that would recognize the need for the policy reform. Through conversations with DHS staff on both the programming and licensing sides, we've come to a temporary agreement, and the Senate committee referred the bill on to the Finance Committee. The amendment does not uniformly grant the age-based variance that we were seeking, but it does ensure that DHS and organizations like ours, including other victim service providers, will work together to resolve those conflicting requirements around licensing, particularly the age of youth that can be served. We've also gotten a commitment from DHS that in the meantime, they will expedite these case-by-case variance requests to the extent possible. Because of the leadership, support, and encouragement of all of the legislators involved, for which we are very grateful, including Representative Koznick, we were able to further this conversation with DHS beyond what we've been able to do in past attempts as a service provider. We're optimistic that this bill will pave the way for broader improvements in the licensing system so that the young people most at risk can get access to the services they need. And we hope that this proposed grant program and appropriations can be revisited in a future session.
Thank you, Ms. Polzin. So the A2 amendment allows the variance but removes the mandate for the funding, if that's my understanding. All those in favor of adoption of the A2 amendment, please say aye. Aye. Those opposed, no. All right, the A2 amendment is adopted. Questions? Representative Loeffler.
Well, thank you, Mr. Chair, and Representative Koznick or Ms. Polzin. I understand that you're targeting a particular group of very vulnerable young people who, many of whom you've referred to as being sexually exploited or in situations of family violence or other. But I'm concerned that the bill is really drafted that could be interpreted and used by others much more broadly, because it also defines vulnerable youth 13 to 17 as just anyone who's homeless. And we know that it's not unusual for children of that age to run away from home when life just gets difficult in a variety of ways. And I think we've built up a really good service system of trying to bring families back together, to bring in supportive services, to not have them think that transitional housing until they become an adult is an option for them, which would look really attractive if you're 14 and you're tired of your parents. And so I'm just worried that your intention is to target it to a really narrow group of exploited youth, but the actual remaining language in the bill still says anyone who's homeless would qualify, that's 13 to 17. It doesn't put other definitions around them that would say they would be treated differently than the ones who you've described. And so I wonder if you could tell me why you think we need to have transitional housing for all potentially available to all youth who are homeless, as opposed to those that you have noted have already gotten themselves into some really dangerous situations and probably need mental health and psychological assessments and support in restoring themselves, a point to move forward.
Representative Koznick.
Thank you, Mr. Chair, and Representative Loeffler. You know, one of the things when the bill was presented to me to author that I thought was important was that it didn't just provide housing services that, you know, somebody that doesn't want to, is struggling at home. I think it's important to provide services that the youth are trying to be unified with their families. And so that was important to me, and that's part of the services that they do at Tubman. So on your first point, that was important to me, and that's part of the services and the suite of services that are provided at Tubman, but included in the bill. And I'll let Ms. Poseen address a little bit more about the other question on the homelessness a little bit and how they how clients and the youth actually come to Tubman.
Ms. Polzine.
Mr. Chair, Representative Loeffler, thank you for the question. To that, I would add that youth who are homeless are typically approached within, we used to say within the first 72 hours for sex of being homeless. They were approached and recruited. Now numbers are pointing more to within the first 36 hours. So homeless youth are very much at risk for sexual exploitation as part of being promised housing and a place to stay. So that is the reason why we try to be broad in our services. Every organization certainly is different, but that is something that many of us agree on, is the fact that homelessness and sexual exploitation and relationship violence, there's a huge correlation there. I understand the concerns that you raise. To that, I would say that, yeah, I'll leave it there.
Representative Loeffler.
Well, thank you, Mr. Chair, and as I assume we'll lay this bill over for possible consideration, and I hope that we can keep working on that, because it does in line 2.4 define vulnerable youth, includes youth who are homeless. So that doesn't say they have other risk factors or other sorts of things. And, 13 is a pretty young age to have someone not have a program that says in its requirements that one of their goals is family reunification and strengthening that family to resolve whatever issues there are and that sort of thing. And I just felt like, your program may be targeted to a very specialized population and work with that group, but this could be, we're writing statewide language, it could be used by others for other purposes. And I just think for children that young, we really do need to look to some other options besides transitional housing. As potentially or we need to define in statute that the services have some other goals than I see listed here. So I'd be glad to work with you or keep talking about it, because I understand your goal. I just think it's written pretty broadly. Thank you.
Representative Fisher.
Thank you, Mr. Chair, and thank you, Representative Koznick, for bringing this bill forward. I think it's a step to address some issues out there. And to Ms. Polzin, I appreciate the work that you folks are doing over at Tubman. One of the things that I'd kind of like to pick up on is a little bit on the licensing requirements. Having worked in the same situation where we're a child residential facility, we've occasionally had youth who've been in who are 15, and it is a nightmare just trying to address the situations. And I've seen youth out there who are in that 13, 14, 15-year-old range where, all of the agencies out there working for family reunification, but in some instances, family reunification doesn't work because there's no family left. And I think this is what I'm hearing, and I would encourage to make sure that as we're addressing this, that we're bringing that component into it and figuring out what does that look like going forward. I've been too frustrated over the years to see youth who are 15, 16, 17 who've been on the streets for 4, 5, or 6 years, and they're being placed in our facility for a month, for a year and a half at a time because there's nowhere else for them to go. And I think the problem that you're highlighting here is one that is serious and needs to be addressed. And so I was encouraged by the amendment to see that it's requiring the commissioner to get together with providers and people in the area to figure out what we can do to better address that problem, because right now the system is not working. So thank you for those efforts.
Thank you.
All right. Representative Pinto.
Thank you, Mr. Chair. And this will be quick. I want to thank Representative Koznick for bringing the bill forward, and Ms. Paulzina, just to, I guess, reiterate one point and add one point. The reiteration is that we teach in the area of exploitation and trafficking, as Ms. Paulzina said, that simply being homeless is a massive risk factor for exploitation and sort of is itself a vulnerability. And so just as far as that goes, it seems to me the vulnerable youth, having that concept of vulnerable youth include a homeless youth makes great sense. And I also like to point out in connection with that there are safe harbor protocol guidelines that were developed. I was led the group that put that together along with somebody from the Minnesota Coalition Against Sexual Assault. I think Tubman participated in that. And one of the recommendations that was put forward by that group was to have additional housing services and transitional housing for youth who are experiencing or at risk of exploitation, which certainly includes homeless youth. So I appreciate this being brought forward. Thank you, Mr. Chair.
Thank you, Representative Pinto. No one from the public had signed up with the pages, but if there's anybody that would like to testify, we'd like to offer them an opportunity. All right, seeing none, Representative Koznick, final word.
I appreciate the committee's time and the consideration. I thank the folks at Tubman for doing the work that they do and others that provide similar services. I appreciate your consideration of the bill, Mr. Chair.
All right, thank you, Representative Koznick and the advocates. With that, House File 3133, as amended, is laid over. Thank you. Next up, House File 4135. Representative Franke, welcome to the committee. I will move House File 4135 be laid over. We have the bill before us. I understand there is an A1 author's amendment. I'll go ahead and move the A1 amendment. Representative Franke, to the bill and to the A1 amendment.
Thank you, Mr. Chair, members. House File 4135 is an appropriation for recovery corps. It's an offshoot of the AmeriCorps program here in Minnesota. And I think as far as what the money will be appropriated for, kind of is laid out right here in the amendment. So I will briefly read the amendment so everybody understands, and then it will give you an idea of what the bill provides. Page 1, line 9, after the period insert, funds shall be used to support training, supervision, and employment of AmeriCorps members to serve as recovery navigators. Page 1, line 12, delete substance abuse recovery services, insert services promoting sustained substance abuse recovery, including but not limited to stable housing, relationship building, employment skills, or a year of AmeriCorps services. This Recovery Corps program put on by AmeriCorps is from everything that I've learned about it, researched about it, it's a great program. It provides services in the gaps of people coming into recovery out of addiction. It's definitely a needed service, and one thing I like about this program is it also allows us to leverage federal dollars for the dollars that we put in. So our return on investment is definitely a positive plus side for the state of Minnesota and its citizens. I know the time is short, so I will just go straight to my testifiers.
Okay,
and I
why don't
will
we
let
go
them-
ahead and put on the A1 amendment? I think you've described it
Mr. Chair.
adequately. So all those in favor of adoption of the A1 amendment, please say aye. Aye. Those opposed, no. The A1 amendment is adopted. Representative Franke, to your testifiers.
Thank you, Mr. Chair, and I will just pass it down the line, let them introduce themselves.
Mr. Chair and committee members, my name is Audrey Suker, and I serve as CEO of Serve Minnesota, and we're Minnesota's Commission on National and Community Service. And we were created in 1994 so Minnesota could receive the federal AmeriCorps resources. The purpose of AmeriCorps is to serve as a powerful tool for governors and policymakers to solve unsolved problems by calling on individuals to give a year or more of service to their communities. Our board is governor appointed and includes 4 state legislators. For the last 15 years, our primary focus has been on helping Minnesota's education system address the achievement gap. And to that end, we have over 1,400 AmeriCorps members right now on the ground working with about 30,000 students every year. However, over the last 18 months, we've been immersing ourselves to try to understand what our role should be in helping Minnesota address the opioid epidemic. From what we've been learning, we believe that carefully trained and supervised AmeriCorps members could make significant contributions across several areas of Minnesota's response. But we're here today because we believe the most immediate need we can help address is the need for individuals in recovery to have assistance rebuilding their lives after treatment. To that end, we're requesting $450,000 to expand our Recovery Corps program from 7 AmeriCorps members today to 35 AmeriCorps members over the next year that would reach over 2,000 individuals in recovery. The state investment would be matched 2-to-1 with federal dollars. And I have testifying with me today is Dr. Pete Nelson, who is our Director of Research, and he will describe the process that we're using to build our recovery program so that it is in fact evidence-based and Katie Boardman, who will share her experience as an organization that is part of our current efforts to pilot the program. Dr. Nelson.
Welcome to the committee. Please introduce yourself and proceed. And please, if you could really kind of try to focus in your testimony, we would greatly appreciate it to make sure that we are able to move the bill today.
Sure. Mr. Chair, committee members, my name is Peter Nelson. I'm the Director of Research and Innovation with Serve Minnesota. The primary role of our team is to ensure that national service is an effective and efficient use of resources. So for us, that means a couple things. We do a lot of work in program improvement, so we make sure that our national service programs are increasing their efficiency and effectiveness. But we also do a fair amount of program development, and this is the work where the area where Recovery Corps fits in. Now, any development project that we engage in, the activities tend to fall into four stages. In the first stage, we assess the opportunity. So that this means that we're looking at, is there a critical need and is it the right fit for national service? In the case of Recovery Corps, the question of need is pretty straightforward in that we know we're dealing with a very significant problem that affects people across all walks of life. So for us, we've been really focused in on where does national service fit along this continuum of the issue. And so the next step then, well, I'll say in the case of recovery, the next step is for us to then develop a program. And recovery tends to be a good fit for national service because for a couple of reasons. First, we know that there are a number of research-based activities that members can engage in to support folks who are in recovery. And there's this capacity need and that there are many people in recovery who aren't able to access those kinds of supports. So when we engage in the development process, we partner with researchers, we partner with practitioners, and we also engage in an internal review of empirical literature to drive program development. And in this case, we focus on this idea of recovery navigators. These are folks who partner with participants to help build their recovery capital. This covers everything from helping folks navigate employment and the housing system to reconnecting with family and friends and perhaps engaging more with the community through national service. So the next step for us is then to pilot and refine the program where we learn a lot about the feasibility of the program as well as the impact. So are we impacting this problem that we sought out to address? And once the parameters of the program are in place, we then would finalize and scale the program with a focus on sustainability.
Thank you. Representative Heinzman.
Thank you, Mr. Chair, and this is probably a question for Dr. Suker. I have a teen challenge facility in my district, and we try to track the success rates over time, and I'm wondering, is there any information, maybe you mentioned it, I just missed it, but what are we looking at in terms of success rates in this program?
To any of the testifiers.
Chair, I would say that it's early in the program. We're just in our pilot year. So right now, we just have 7 AmeriCorps members on the ground. But as Dr. Pete Nelson is explaining, we are going to be carefully tracking our success and partnering with Dr. Kelly from Harvard University to make sure that we are building empirical evidence that this recovery capital is resulting in sustained recovery. So I think that's one of the reasons that we are requesting some pilot money so that we can scale the program and come back to you with a sample size large enough to have the empirical evidence that we expect to be there.
Chair.
Representative Heinzman.
Thank you, Mr. Chair. So just follow up quickly. Are there other similar programs that maybe are established in places around the country that you could point to that have a success rate that would justify the cost?
I would say that Dr. John Kelly from Harvard, he is working closely with us, and his research indicates that the building blocks of recovery capital, that there is evidence that that sustains recovery. So what we will be doing is taking his research and bridging a lot of that research into practice.
Yeah, and so if I can just add in a little bit there. Yeah. So there are recovery supports for folks, but one of the reasons that we chose to focus in on recovery is because there is this huge capacity gap where there's large numbers of folks who leave treatment and they really don't have the kinds of supports that they need to stay in long-term recovery. So there are sort of exemplars, and we're using those as a guide for us in development. And we're refining how we define recovery capital and specifically focusing on areas that would have the highest yield. Certain areas that if people can build this kind of recovery capital, they can stay in long-term recovery. And I'll just mention to the data question, again, Dr. Kelly's working with us to develop a comprehensive data system. So we'll be able to monitor how long folks are in recovery, how many relapses, if any, sort of a monthly data collection record that'll inform member activities, but it'll also give us hard data on program impact, which is something that we care very deeply about.
Representative Franke.
Thank you, Mr. Chair. And Representative Heinzman, the bill does also speak to the fact that it is requiring that they do a report, a commission's report to the legislature. So they'll be collecting that data and getting back to us with that.
All right. Please continue with your testimony. I think that you have one testifier, Ms. Boardman, that hasn't spoken yet. Welcome to the committee. Please introduce yourself for the record and proceed.
Hi, my name is Katie Boardman, and I am the administrator for the Minnesota Association of Sober Homes, also known as MASH, and the National Alliance for Recovery Residences. I also serve as the Director of Operations for St. Paul Sober Living. MASH promotes the establishment, successful management, and growth of high-quality, community-based sober living residences. We provide a standard of living that goes beyond locally regulated requirements and is dedicated to the dignity and worth of all that we serve. Currently, we work with 145 homes that have approximately 1,350 residents ranging in age from 18 to 70, all of whom identify as addicts. We provide the safe and supportive environment these individuals need while they're working on their own recovery plans. We were excited when we were approached to be one of the first programs to have a recovery core navigator. We knew we could utilize them in significant ways to help residents implement their recovery plans while at the same time providing them with a meaningful AmeriCorps experience. Our recovery core navigator, Alex, is a blessing to us. She's in her early 20s in recovery and is a resident of one of our homes. We couldn't ask for a more amazing person. Because of her personal experience, she understands the process and is an excellent resource to help navigate the complicated and sometimes frustrating path to recovery. Trained peer-to-peer support is something that residents can't get anywhere else. She helps them to answer the question, so I'm out of treatment, now what? Residents are expected to get a job and become active members of society. Alex is the link to help them get on the right track, developing resumes, identifying training and educational opportunities to build job skills, and finding volunteer roles that help them serve with purpose. The number of young people in recovery has increased dramatically over the past few years, and unfortunately, in addition to coping with addiction, often have not yet acquired basic life skills, such as how to budget or even how to ask for help. Alex provides them with the tools to gain self-sufficiency and makes it fun so that they stay engaged. One resident had severe anxiety around public transportation. It was easier to stay home, so she missed meetings and was unable to get to work. Alex helped her get over that fear, which has now opened up a world with endless possibilities. While this was a literal example of being trapped, so many of the residents feel isolated and scared of doing things. Alex helps build community and, more importantly, confidence, so these individuals can become gainfully employed and maintain their sobriety. This level of extra support doesn't exist anywhere, and if it does, it costs money that they may not have. A lot of families have exhausted their resources getting them to this point in their recovery, and to provide this type of support to those who may not be able to access it any other way is amazing. Alex has helped over 130 members of our recovery community who can now share that knowledge with others. The impact of this program already has an incredible ripple effect. We know that involvement in the community is key in early recovery, so making those connections can't be left to chance. How exciting it's been to be a part of Recovery Corps in its beginning. Because of my work with the National Association, I can tell you that other states are really jealous of what Minnesota Recovery Corps is doing, and they hope it will expand to more communities in Minnesota and across the country. Think of the possibilities. I know that if there are more Alexes in our communities, it would literally save lives. Thanks.
Thank you for your testimony. Is there anyone else in the audience who'd like to testify on this bill? All right, seeing none, we'll close off the testimony and open it up to member questions. Members. All right. Final comments, Representative Franke.
Thank you, Mr. Chair and members, for your time and for your support on this bill. I would just like to say that programs like this, and this program being in its infancy, is something that we really need to put our money into. We need to put our money where our mouths are when it comes to supporting people within our society. This helps to fill the gaps for those who might not be blessed enough to have those support systems or those family members who are going to help prop them up when they get out of treatment and begin their life in recovery. And that is such a crucial time in a person in recovery's life that those necessities are just what you need to have, because I've always said that, we send people to treatment and they get out 30 days, 60 days, whatever it may be, and without those support systems, the likelihood that they're going to be successful just declines. So I just want to say that our return on investment in this program. I mean, we're leveraging financial capital to invest in human capital, and that's what I believe Minnesota's all about, so thank you.
Thank you, Representative Franke, and thanks for your work on your subcommittee and all of the great work that you are doing on that. And with that, House File 4135 is laid over. Thank you. Next up, we have House File 3650 for Representative Kresha. Welcome to the committee, Representative Kresha. Representative Kresha, I will move House File 3650 be laid over. We have the bill before us. There's no amendments. Representative Kresha, to your bill.
Thank you, Mr. Chair, and I'll be brief. This is a bill and a program that many of you are aware of, and I'm back this year because of the success and also the allocation that we had last year. Anytime we move through the early stages of a program, it takes a while to get things up and running. So everything's starting to come up to speed, and we have some successes, and so we're back here asking for a continuation. I won't spend a lot of time with it because the two folks that have been at the front and center of this, Dr. Devine and Dr. Bell, know it much better and frankly have been the champions and the advocates, so I'd like to turn it over to my testifiers.
Welcome to the committee, testifiers. Please introduce yourself in whatever order you would like and proceed with your testimony.
Thank you, Mr. Chair. My name is Kurt Devine. I'm a physician at the Family Medical Center in St. Gabriel's in Little Falls. I just like a couple disclaimers. I think that often when we're talking about opioids, I think that we're looking at everything. I'm going to talk about doom and gloom, and I'm not going to today. I think we're going to talk about hope and what we're trying to do to fix this problem. The other disclaimer is we are not addiction physicians. Both Dr. Bell and I are family doctors in Little Falls who've been working on this program for 3 years now. We are working on two programs. One is with MDH, which is this program. We're also doing something with DHS through doing rural teaching for opioids prescribing and for medical assisted treatment. And this one is, today we're here about the other. We do have handouts. I don't know if we...
Page has them.
Oh, wonderful.
They're being passed out.
Perfect. And we were asked to do this program by MDH because of the success we'd had in our program. We have been doing this now for about 3 years, where we started in our clinic basically walking ourselves through every single patient that we had on controlled substances using a team of a social worker, 2 physicians, a nurse, and a pharmacist. And over those 3 years, we have stopped almost 500 people's medications that they really didn't need. We have cut out 500,000 pills that were controlled substances in our clinic during this time. And so we've shown that you can do this if you really take the time. And I think it's important for people to understand when you look at the heroin addiction that 4 out of 5 people start with the pills that they're getting from our clinics. And so we look at the front end of this. I think that often people come and they want to talk about medical assisted treatment as a primary thing, but we're trying to keep people from falling down that path by not getting them the medications that they frankly sometimes don't need. And so that's really the most important part. The second thing that we are teaching and that we are bringing to these 8 communities that we'll be dealing with is actually medical assisted treatment. As you know, all the addiction doctors are in the Twin Cities, Duluth, and Rochester. There are not addiction specialists in the metro or outside of the metros. And part of our progress is really to put those people out in the rural communities, and we've done that already, and we're going to continue to do that so there's access for the people living in those small towns and those rural towns. And I'll let Dr. Bell talk a little bit about what we're doing in these towns and exactly what finances and such they've gotten as a part of this program.
Welcome to the committee, Dr. Bell. Please introduce yourself and proceed.
I'm Heather Bell. I'm also a family physician in Little Falls, Minnesota. So finally, we just got our 8 communities selected. 4 of these communities are all getting $100,000. The other 4 communities are all getting $75,000. With that money, those communities will be building their teams similar to what we have in our community. They need a physician, a nurse in the least. Some of them are using that money to get a social worker and a dedicated physician, so physician time to really work on their program. Basically, in order to get the grant, so these 8 communities all needed to have a community task force, so members of each community, not just the clinic people, but community members have to have a task force. And then they needed their team in the clinic to really sit down and be able to go through patient charts one by one. They need a nurse that's dedicated strictly to monitoring patient charts and helping support the physicians in their clinic, getting care plans done, monitoring urines, monitoring patient prescriptions, and then they needed to get physicians waivered and buprenorphine, so their Suboxone waiver to do the MAT. Really, another component is really the patient-centered medical home, so whole person care. We really want to make sure that in our rural communities, patients aren't just fired from clinics if they have drug issues, but rather they're treated with a comprehensive care plan. Obviously, these communities will need to do data. They'll need to monitor their pills, their care plans, how many buprenorphine patients they have, how many overdoses they are not having as many of. And with this, we're able to mentor these communities. The goal is to really be able to get on the ground, explain to these communities, mentor, be there for these communities, whether it's us going to their communities or using our telemedicine echo program that we also do to really show them that this is possible in their communities. This is a very overwhelming problem that all these communities have. We want to say, hey, we wrote this book, which we have a manual we're giving to them. We've already worked through all the workflow. We already know how these processes work to be able to really just get there and help them just get started to have the same success. And again, focus on getting the pills cut out of their communities. Our goal right now with our 8 communities is to cut 1 million opioids out of the state, which we totally think is possible. We've had other communities across our state just starting, and they've already cut hundreds of thousands of pills. A million pills, roughly about $7 a pill. That's $7 million saved in just the pills, and that's not counting the emergency room visits, all the phone calls for early refills, and all the other services that most of these patients are on state-funded insurance. I mean, that's a lot of money that we're hoping to save the state in just the pills. And then, of course, be able to treat the patients in rural Minnesota who have already gotten to the addiction problem.
Thank you, Dr. Bell. We appreciate your testimony and for your work, and Dr. Devine for your work in pioneering efforts in your area. Is there any other testifiers that you have, Representative Kresha? Is there anyone from the audience who would like to testify on this bill? Seeing none, we'll close the test. Oh, is there somebody? All right. Please make your way down to the testifiers table. Introduce yourself for the record and proceed with your testimony. If you could keep your testimony to 2 minutes or less, we would greatly appreciate it. Welcome to the committee.
Hi, my name is Andrea Hunt. I'm a nurse at the University of Minnesota Masonic Children's Hospital. I work on the postpartum floor, and I'm actually here as part of the Student Nurses Day on the Hill. And I want to speak really briefly about opioids. Pardon me if you've heard these statistics, but in Minnesota, opioid deaths have gone up 430% since 2000. And as you stated, 80% of Americans addicted to heroin start out using prescription pain medications. On the postpartum unit, opioids are a far-reaching problem. If women don't get into treatment, there's the healthy infants that come to my unit that are watched for drug withdrawal, and if it's bad enough, they go to the NICU. But many of these infants whose moms come in on the opioids, they're put into a 72-hour hold. A lot of them will go into the foster care system. And from 2015 to 2016, there was more than a 10% increase in overall children placed in foster care for the first time. And according to MDH reports, that's a directly related to the opioid crisis. So the need for comprehensive interventions in clinics is really important for these mothers to not come in. And starting in 2016, for the first time, drug abuse was the primary common complaint of kids being removed from homes over alleged parental abuse.
All right, thank you for your testimony, Ms. Hunt. We do appreciate it, and thanks to all of the students from the University of Minnesota who are here today. Member questions, Representative Liebling.
Thank you, Mr. Chair. Not really a question. I just really wanted to, commend the testifiers for your great work. And I remember when you first came just to report on what you were doing, and it was so impressive. And like you say, to hear actually something that's working. It's been a long time concern of mine that the PMP, the Prescription Monitoring Program, is, I've been kind of a skeptic, I would say, of that program because it gives physicians a tool or prescribers a tool to know when somebody might be in trouble, but then it just doesn't, there's nothing to follow up. And what you folks are doing is following up. And so when Representative Kresha asked me to sign on to the bill last year, I guess, I was very happy to do that because I really think this is a great approach, and I'm really glad that you're modeling this for other communities, and really appreciate your efforts and wish you a lot of continued success. I hope we can fund this. Thank you.
Great, thank you.
Representative Considine.
Thank you, Mr. Chair. The 8 communities, is that a secret, or can you tell us who they are?
They have not been released yet. They are chosen, but we were asked not to yet.
Oh, okay, thank you.
It's a secret. All right, further questions? All right, seeing no further questions, thanks again for all the work that you're doing, for sticking your neck out and trying something that hasn't been done before. It's been very successful. We appreciate that, and appreciate you practicing in Minnesota, and appreciate you taking time away from your patients to be here today. Representative Kresha, final word.
Thank you, Mr. Chair, and thank you, members. Yes, what a fantastic program. And one of the things that I just want to highlight, or 2 things that I want to highlight that the testifier, the nurse came up, Ms. Hunt said was, this is directly tied to child protection, which is something that's near and dear to me as well. We know this ties back, and we need to have second and third generation solutions if we're going to change this. And the second thing that I just want to highlight that this group has demonstrated to me is this is not, there is no easy fix. There's no magic program. It's a grind. And it's a every day, day in, day out, try to take just pills off the street. I mean, there is no magic wand. It's a grind, and they've demonstrated that. And so I thank you for your support, and I hope we can continue with that.
Thank you, Representative Kresha. And with that, House File 3650 is laid over. Thank you. Next up, this one. Representative Zerwas, House File 3132. Representative Zerwas moves House File 3132 to be laid over. We have the bill before us. There are no amendments. Representative Zerwas to House File 3132.
Thank you, Mr. Chair and members. House Bill 3132 is intended as a step towards lowering Minnesota's health care costs, particularly in Medicaid. An innovative company, Cornerstone, has worked for years to develop a process to capture unrecovered third-party liability dollars owed to payers like Minnesota. And they've been awarded a patent for this process and are eager to put it to use. What this bill would do is call for an RFP to be put out that would be open to all competitive bids to collect third-party liability payment. Currently, the state does a good job collecting some third-party liability payments using presently available processes. However, they don't go to the full extent of what technology now allows. Over the last several years, there's been a great deal of talk about controlling healthcare costs. Many of these ideas are simply not going to happen, and others are too grandiose or require federal cooperation in order to happen. This bill represents something that is today doable and tangible. What we have is something that could be a significant step in the right direction. I have Louis DeLong of Cornerstone who will explain how one of these processes works and what problem it proposes to solve.
Welcome to the committee. Please introduce yourself and proceed.
Thank you, Mr. Chair. My name is Louis DeLong, one of the co-founders and one of the patent holders for Cornerstone Medicaid. We developed a process that we received a patent on to help identify or potentially identify third-party liability that we believe is currently being missed. For an example, if someone gets a knee replacement and they were in an accident 9, 10, 12 months ago, 18 months ago, a lot of times that's never disclosed and it could be a contributing factor. So we developed a process to identify that, and then using medical review boards, medical professionals, to determine if it is a contributing factor or not, and then being able to go after those funds.
All right. Thank you for your testimony. Is there anyone in the audience who'd like to testify on this bill? Seeing none, we'll close off the testimony portion and open it up to member questions. Are there questions by members? Seeing none, final word, Representative Zerwas.
Thank you, Mr. Chair. Thank you, members.
All right. With that, Representative Zerwas, House File 3132 is laid over.
Thank you, Mr. Chair. Thank you, members.
All right. All right, next up, we have House File 3139. This is one of my bills. If it's okay, just to save time, I'd like to present from the chair unless there's anyone has a problem with that. Be happy to do it from the testifiers table. Otherwise, I will move House File 3139 to be laid over. There is an A2 amendment. This is Representative Loeffler. And Representative Loeffler moves the A2 amendment. Representative Loeffler was nice enough to chat with me a little bit about this yesterday, so I'm familiar with this. Why don't you please introduce the amendment, Representative Loeffler?
Sure. Thank you, members and Mr. Chair. And, you know, this may need a little bit more work before we're laying it over, so we can still work on the language. When I looked at the bill, I thought, you know, and understood a little bit about what the target was. I felt like the definition of who qualified was a little loose in terms of who is medically complex or technology dependent, because it could be interpreted a bunch of different ways. And we do have in law the program that's the community alternative care waiver, which is people who need basically hospital level of care and supervision. And I thought that was a good way to define what we needed. And then my understanding was that part of the reason for this is because we have people who can't get discharged out of hospital, or because of the workforce shortage, we're not able to find the kind of specialized medical talents that they need to provide that care in a home or community-based setting. And so that I felt that we should target it to those areas where we have evidence that people are not being able to be discharged, or are not able to have their children's needs met because of the workforce shortage. And so those are the two changes that I've recommended in this amendment.
All right. And we have Ms. Susan Wingert, who's also with us to testify today. And most of the folks on this committee have heard this bill before last year, and also in policy committee, but not everyone on finance is on policy. So just maybe Ms. Wingert, if you want to just give us like a 2-second intro to what this bill does with the complex care for daycare for kids with lots of complex needs, kind of what the idea of the bill is, and then we'll go ahead and adopt the A2 amendment.
Mr. Chairman, members of the committee, thank you so much. Representative Loeffler, I totally agree. That's a very fine definition of medical complexity, and I would be delighted to have that as part of the bill. The one where we talk a little bit about PPACs is it's a bill that provides care for those exact patients that Representative Loeffler described. And its purpose is to allow children to find an environment that they can be in, where they can come, they can be cared for while their parents work, and then they go home to their families, their mothers, their fathers, their brothers, their sisters, and their pets. It is not meant to be residential. It is not meant to be facility. It's meant to be a normal daycare. But the only difference that we have is it's made for complex care for these very medically technology-dependent kids. We've been working on this for a long time, and we think it is certainly not the be-all and end-all of reducing the workforce shortage, but we do believe that it's a baby step forward to help parents be provided with different options for their children.
All right. With that, let's go ahead and adopt the A2 amendment. Or,
can I just ask one question, if I might, Mr. Chairman?
you can give a comment, and I can ask a question, probably.
Okay. I'm concerned about the phrase where they're talking about areas of the country or the state that are documented as having workforce shortage. One of the things that I need to emphasize here is we also need a population of children. So we may find a workforce shortage up in, say, North Home, but there may be only one child there. And so it probably wouldn't constitute the ability to provide a PPAC. there is a workforce shortage in the 11 county metro area, and we would find enough children to be able to support a PPEC. So my only concern is that although the commissioners certainly may, and I would be delighted to look at rural areas, I am concerned that we might limit how many PPECs we could have by that.
All right, Ms. Winger, thank you. And so as I look at the A2 amendment, and your concerns are with lines 1.13 and 1.14, the commissioner may limit the issuance of PPEC center licenses to PPEC centers located in areas of the state with a demonstrated home care worker shortage, and that there may be some issues with that we might have to deal with. And that sounds like a legitimate concern. Representative Loeffler, do you have a comment on that?
Thank you, Mr. Chair. I think we'll have some time to work on language. It's discretionary, but the idea is if we're going to pilot these, we should actually try and have them step up in the areas where there is truly no other options for the families, because that's what the need is to address. And so, and I understand that you need a certain number of children to make it cost effective or to have it, but at the same time, it really should be targeted to the areas that have a demonstrated need. Otherwise, I suspect many families would, if they are able to find skilled healthcare workers, would prefer to have their children served at home or in a community facility if that's where they're able to find the right kind of medical personnel.
All right. All right, further questions to the A2 amendment? All right, seeing no other questions, all those in favor of adoption of the A2 amendment, please say aye. Aye. Those opposed, no. The A2 amendment is adopted. All right, next, we have another testifier. We have Stacy Vogley. Welcome to the committee. Please introduce yourself and proceed.
Thank you, Mr. Chairman. My name is Stacy Vogley. I've been asked to speak today because I have a daughter that is on the CAC waiver she just mentioned, or has been using home care nursing since 2002 when she was about 6 months old. She's now 17, and she's using 60 hours a week of complex nursing care. But because of that 17 years of experience with my own child and her complex cares, I was asked to talk about this PPEC proposal that is being put forth in HF 3139. I also served on the legislative committee just a little bit ago on the home care nursing shortage with Representative Zerwas. And so I am familiar with this nursing care situation. So this, and the area is familiar to me and many of these legislators, as we all can agree that the nursing staffing shortage needs to have some shifts and some new ideas put in place to find a way to provide competent care for more children with the complex needs. Kids with complex needs are being diagnosed every day, and as proof of my own child, living longer due to the advances in the diagnosis and their treatment, which also includes the care they get in their homes to keep them out of the hospitals. In the last several years, and me being more involved in all this nursing care shortage issues, I haven't actually seen anything new or creative ideas out of the box thinking, unlike this one. This one is a new idea outside of the box, if you'll allow me to say that. There's been people talking about increasing nursing salaries. That might help some, a little bit. But the problem is there's just not enough bodies of nurses throughout the entire state, and especially here in the metro. There just aren't enough of them to cover all the patients. So that said, this PPEC idea is new for the state of Minnesota. And I actually thought of something like this when my child was an infant, that wouldn't it be delightful if there was a highly specialized setting where I could take her on the days our nurses called in sick. When she was 5 months old, I was trying to make a living as a brand new lawyer and an associate, and I was having unreliable staffing issues, and there was no one else for me to give my case to. And so I ended up having to withdraw my practice and give up my career as a lawyer. So by the time she was 8 months, that career was over. And I still had several $100,000 in debt, to cover that cost. But I had to stay home and care for her because the staff weren't reliable nor trained as well to recognize her needs. And having a daycare like this would have been a blessing, to at least take her, it might have saved my career, or at least on the days when I was at home with her, it would give me a few hours where I could have dropped her off for a few hours and either get much-needed sleep, time with her older siblings, or to run errands like a grocery store. I mean, these kiddos need one-to-one care 24/7. So if you don't have staffing, you're pretty much, that's it, you're there, you're stuck. So I actually would have considered this as a valuable option when she was young, and I actually still would today, because there's still days where I have nursing that needs a day off. I think we can all agree that we need to find some solution to the nursing shortage. It's not the intent of this proposal to segregate kids. Rather, it's to find safe and competent care with small staff ratios by highly trained staff. And it's actually possible we can provide better care in some ways, because this model will get enough kids together that you can get more providers to them to start implementing early services to help give them as much independence as we possibly can. And I think it also would give some parents that struggle to get their kids to all the different providers that they need. Complex kids can see as many as 20 different specialists, and we're talking several appointments a month, as many as 10. So in short, I think that this HF 3139, is a good effort to provide a valuable option for parents that are desperate for help for even a few hours of care for their medically fragile kids. Thank you all for the chance to provide my opinion.
Thank you for your testimony today. Is there anyone else in the audience who would like to testify on this bill? All right, welcome to the committee. Please come forward to the testifiers table and introduce yourself for the committee and proceed with your testimony.
Thank you, Mr. Chair. I am Debbie Harris. So my name is Debbie Harris, and my husband Victor and I are the parents of Joshua. He's a young man who is medically complex, technology dependent, and who has significant disabilities. Joshua is 25 and has received nursing care in our home for his entire life, after being discharged from a long and arduous hospital stay at birth. We are very much aware of the tenuous nature of home care nursing and its many systemic challenges, but believe that home is the safest, most nurturing environment for our son. We are fortunate. We have a couple of dedicated nurses we trust, as well as supportive family members who are trained to fill in when nursing is not available. Still, I do have some concerns about HF 3139 and the potential for exacerbating disparities in an arena that is already easily vulnerable to inequities. Simply put, because of nursing preference, socioeconomic dynamics, cultural sensitivities, and other easily misunderstood issues, there are some children and young adults who will have little chance of experiencing anything other than receiving a large part of their care outside of the home, and everyone deserves an opportunity, like Josh has had, to thrive at home. One of my master's theses researched how cultural competency has played a significant role in home care nursing for medically complex children and their families, and it's proved to be a timely issue. A lot of the culture of home care nursing depends on who you are and how people perceive you. So when Josh was an infant, he was the sickest baby in the NICU, and at that time, we were told that we should give up even having anyone work on Joshua because of his complex needs. It was determined that we were probably not people or family that was capable of caring for Josh at home. We wouldn't have the resources or the capabilities to care for a child such as Josh. And that was based upon a person, the physicians, just kind of looking at us and placing their kind of stereotype perspective on us and our ability to care for Joshua. We've had home care nursing for many years, so we kind of know the ropes. And we've had a number of, we've had every kind of scenario you can imagine in the home. We've had a number of meet and greets where we want to make certain that the nurses who do come to our home are a good fit for Joshua. We have a very nice setup for Joshua. We have a lot of modifications, and And these days, as Susan knows, you have to almost brand yourself and market yourself so that you can be like the winning family that gets the nurses. But I've actually, we've had meet and greets where I've answered the door and had a nurse come and, open the door and had someone not expecting to see me there and say, "Oh, could you go get Mrs. Harris for me?" And I've said, "Surprise, it's me." But my intention here is to continue the discourse, to bring to light potential barriers for marginalized populations that have the potential to be further marginalized if we don't recognize some of the ways that families who aren't those preferred families to get the staffing can be kind of left behind. So a couple of things I want to be able to talk about when we look at this bill is that physician groups don't always discharge patients with consistent guidelines or consistent perspectives. And much of home care staffing, not with Susan's group, but with other groups, is based on nursing preference. It's dependent on that so agencies can keep their businesses going. And so when you base it on that, there are a lot of biases involved, and that's part of the home care nursing culture. And it's often based on race, language, location, and culture. And so some families are more easily staffed than others. So some will end up having to use a place outside of their home where others might not. And so thus, like I said, some families are more easily staffed, which can greatly shape the trajectory of a family's life and their experience with their child with complex needs. So while I do acknowledge that I speak from a place of relative privilege in that we have 2 nurses right now, which is amazing in this day and time. We have one night nurse who works 4 nights a week and one day nurse who works 4 days a week. And my 85-year-old father sits with Josh 3 evenings a week, and we have family that fills in otherwise, which is actually like a miracle in this environment right now. I just think we need to continue the conversation. We need to make this the best outcome and the best solution that we can for everyone involved so no one gets left behind and we don't just have like one particular group of poor or minority or not easily staffed kids who have to go have to be outside their home. And then one more thing I think we should look at in the language of the bill is that we have TRICARE. My husband is a retired Marine, so we have military insurance. And right now, Josh is on TRICARE for life. So they do have language for home care nursing, which, by the way, I had to fight to make them pay for. But that's a long story. If you want to hear it, just meet me out in the hallway. But in any case, but TRICARE standard, they have changed their language for home care nursing. And so in a state where there is a PPEC, they will not allow you to have nursing in your home anymore. So you don't have a choice. You have to take your child outside the home and get your nursing in this type of a situation. So I think we need to look at that too and make some allowances in the language of the bill for that. So I thank you for your time, and I just want to make certain that we can have longer conversation, maybe a stakeholders group, and make sure that we're addressing all of the concerns on a long-term basis for the bill.
Thank you for your testimony today, Ms. Harris, and thank you for your advocacy on behalf of your son, Josh. Thank you for your previous testimony. And as the bill moves forward, I would be happy to have your input on this bill. I think you bring up some good insights and good suggestions, so I would be happy to work with you personally on that as well.
Okay, thank you.
All right. Are there other testifiers that would wish to testify on behalf of the bill? Welcome to the committee. Please introduce yourself for the record. And if Ms. Harris, if you could check in with the page and leave your name and address, please. Welcome to the committee. Please introduce yourself for the record and proceed with your testimony.
Hi, I'm Jean Bender, and like Debbie, I want to continue the conversation. I have a little bit different perspective than she does. 45 years ago, I was in elementary school in St. Peter, in the same school that shared space with children from the St. Peter State Hospital. Those children were not a part of our school. Rather, they used the hallways at different times than other students. Their lunch period was separate. Their recess was separate. Everything was separate. If paths crossed, our teachers would hustle us out of the halls and into our classrooms. And I feared those kids because of the adult reactions to them. Fast forward 20 years. I have a son with multiple disabilities and fragile health. When we were raising him and times were tough medically or behaviorally, my own mother said, "It's too bad the state hospital's closed for kids like him." But a state hospital's not a place to be. And I caution placement in any center that isolates them from families and peers who become visitors in children's lives rather than family members, classmates, and neighbors. The problem with expanding center-based programs for kids and families in crisis, medical or otherwise, is that it isolates them from the community. Their crises stay their crises. People and informal support networks can say, "Isn't there a place for that?" instead of, "How can I help?" And then people start competing for placements, and temporary stays get extended. I realize this isn't a residence, but I also know that often 16 hours a day can become 24 hours a day. We can take a step in one direction, and then the next time we come to the legislature, we're asking to expand that step, take another step. And so I caution that we consider that when we're doing this. My son's 31 now. When he was growing up, there was no Olmsted plan in Minnesota to ensure community first, home first, family first. And every time I tried to enroll him in an inclusive program, be it educational, recreational, or adult service programs, I've been told, this program is not for him. This is for kids or adults or people who are more independent than he is, who are less needy than he is. And I fought like heck to keep him in his community. And so I worry whenever we want to say the answer to problems is let's find a place, let's make a place. I do know what I'm talking about. My son spent over 60 days in the hospital in this past year, and my husband and I were with him 24 hours of those 60 days. That includes taking shifts, sleeping at home, and being with him. So I understand how complex some of these kids are and some of these issues are. He's home now. He lives with us in a duplex. Half is his home, half is ours. And when he doesn't have staff, one of us is in his home with him. And we're continuing to work to build the support system that he'll need when we're gone. I understand not just the situation, but the very good intentions of Representative Dean in Pediatric Home Services. Are there problems for families who desperately need support for their children? Yes. Are there workforce shortages causing crisis? Yes. But is this the answer? I'm not sure. Fix the disparities that pay institutional care workers more than home care workers. Support families better who need in-home care services for their children, rather than over-monitoring budgets for potential fraud and creating layers of paperwork to approve every expenditure. And I know that. In this past year, I've had to add a ramp to my home. I got a shower chair denied because I flipped the timeline of when I ordered it. So it's really hard when you want to take care of your kids at home. There's lots of hoops to jump through. And so if we have $500 a day to pay a facility, give families access to $500 a day and see if they can maybe make it work then, rather than tying the funding to a placement. I urge you to be cautious in funding a Band-Aid that won't fix the broader issue. Children deserve to be in their homes, not places and care residences or anywhere else. I don't want the answer for families who desperately need services and supports. Send them there. Because if there are beds to fill, they'll be filled. And the children will be someone else's problem. Our history's taught us that. Thank you for listening.
Thank you for your testimony, and thank you for your advocacy. We do appreciate that. Is there anyone else who'd like to testify? All right, seeing none, we'll close the public testimony, open it up to member questions. Representative Liebling.
Thank you, Mr. Chair, and thank you to all the testifiers. It's been very, very interesting. I just had a couple basic questions about the bill. One is how the rates were arrived at. So it has 500 full-day rate, $250 half-day rate. So that's one question, maybe for Ms. Wingert or maybe for the author of the bill. And then second question I have is more to the fiscal note. I've been looking through it and just got this, and I don't see anything in there about transportation. And I assume that there would be MA, since these children are covered by MA, that MA would also cover transportation to the facility and home again. And I don't know if that's in here or not.
Representative Liebling, just to the first part of that after the policy committee hearing on this bill, we did kind of go through some of the application process for arriving at the per diem rate. I asked for that information and was given that in terms of breaking it out. Perhaps Ms. Wingert can go through that a little bit briefly, and then Mr. Berg can respond to the fiscal note perhaps and address that piece of it. Ms. Wingert, if you want to address the first portion of that, which is how do we arrive at the per diem rate? Understand that this is a new deal and haven't done this before, so we're trying to feel our way and figure this out. But just how do we get there, and what are the pieces of that?
Mr. Chairman, Representative Liebling, Committee, what we were asked to do was to do a cost study, and we received a form from the Department of Human Services that we followed, and it asked us to put dollars to different areas of cost. We did that, and what I can tell you, and I want to be clear, Chairman Dean mentioned it, we've never done this before, so what we are doing here is our best estimate. We also have a part of the bill that says we're going to look at that on a regular basis to kind of pull it together and make sure it's where it's supposed to be. This is the costs that we came up. I believe, and I have a lifeline here who knows much more about this than I do, but 90% of them are direct care providers for the children. 10% is administrative work. And so what we believe we're doing here is providing an alternative that is cost about the same amount as 12 hours a day of home care nursing. So we've got a little bit of a comparison there. And although I certainly won't put my life on this, it's our very best estimate at this point.
All right, and as I look at the breakdown of the costs, it looks like 70% employees' salaries, 20% benefits, 10% operating. Most of this is in people care. This isn't medicine or oxygen. Those are going to be billed differently. But the cost of this is the cost of the center, most of which is people.
Yes, sir.
That was kind of my question, Representative Liebling, as well, is just how do you back that out, and how do you bill for that, and what's the pieces of that? And then that was working with the back and forth with the department. They've broken that up into lots of sub pieces as well that I can share with you, Representative Liebling. And the other piece, I believe, was on transportation. And Mr. Berg, if you could maybe just address the fiscal note, which we just, I believe, received sometime today.
Yes, Mr. Chairman, members, the note does not specifically address anything on transportation costs. You're right, Representative Liebling. I mean, the costs are primarily the $500 a day or $250 a day or half-day rate, and then admin costs relative to setting up the program and running it. So there is no assumption that I'm aware of that there would be any kind of additional transportation payment.
Representative Liebling.
Well, thank you, Mr. Chair, and that kind of concerns me, Mr. Berg, and I think it's, you know, for the department, I think that's kind of an oversight, because there's obviously got to be some transportation, and some of these children are, you know, they require pretty special transportation. They've got equipment that's got to move with them and stuff like that. So whereas some of the costs in the bill are substituting for other care, because I did see that, but transportation, I presume, would be additional, because maybe, well, Ms. Wingert has something to say, I guess, about that.
Ms. Wingert.
Mr. Chair, Representative Liebling, our answer to that is the family will get the child to the daycare center, just like any other parent would do. Just for your own purposes, although if a child is imminently ill, then a life service like an ambulance would be called. But any other time, a parent transports their child to clinics, they transport their child to recreational activities, to any other kind of thing. So we just have them coming there and picking them up. And it has been done in many other states, and it works. And we believe that is the first plan that we have for that.
All right. Representative Liebling.
Well, Mr. Chair, I see there's some little discussion going on here among House research staff about this, but, I mean, I don't see, you know, maybe the practice of many families is to transport their own child places, but I can't see how these children wouldn't be eligible for MA to pay for, well, maybe they wouldn't be. I don't know. I guess that's just really a question that's out there, and I don't know if there was cost to this, whether it would be significant or not. Mr. Berg, maybe you found out something more about this, or, I mean, I just think, Mr. Chair, we need to follow up on this a little bit to get a definitive answer if we're going to move forward.
Fair enough, Representative Liebling. Representative Loeffler.
Well, thank you, Mr. Chair, and I would like to echo that need to follow up on that. 20 to 25% of the people I represent, depending upon neighborhood, do not have one vehicle in the household, and they're as likely to have a severely disabled child as anyone who's lucky enough to have a car. And I think we really just ought to factor that in as we're moving forward and assume that it's not going to be something that's only available to upper middle class people who can afford a specialized van or something else, but that it's actually available to any family that needs it, and that they would get transportation support if they needed it.
All right. Thank you, Representative Loeffler. Representative Liebling.
Thank you, Mr. Chair. You know, I think I'd like to see if anybody from DHS, if we can take a few moments to do it, could come down and talk about this issue, and maybe to address the issue about the rates too, if they could.
All right, welcome to the committee. Please introduce yourself for the record and proceed. We do have one more bill that I need to get through today, so if you could be very brief, please.
Mr. Chair, my name is Carrie Erber with the Department of Human Services. When we put the fiscal note together, we did not assume transportation costs because we assumed that the families would get them there. And you were wondering about whether or not they would qualify for medical assistance. This is adding a prescribed benefit to medical assistance, so I believe that they would qualify. And hope, yeah, we can double check on that, but.
Right, and Mr. Chair, I was more wondering too about a comment on the rates that I'd asked about before, the 500 and the 250. Is DHS kind of in alignment with that? We heard the process described of how we got to those rates.
Oh, we have Alex Bartalik here too.
Ms. Bartalik, welcome to the committee. Please introduce yourself for the record and proceed.
Thank you, Mr. Chair. My name is Alex Bartalik with the Department of Human Services. The department would need to have a process of justifying the rate. We did just receive information on Friday. We haven't had a chance to go through it. We would, in order to submit something to CMS, we would have to go through a process to assure that we can explain the basis of the rate and other factors that they would be interested in.
Okay, well, thank you, Mr. Chair, and not to belabor this, but I'd sure like us to do that before we pass a bill because, right now we're in this little pickle where we had, people were expecting, for example, a 7% more than they're going to get because CMS just declined one of our rates that we had asked for. So I would hate to have that happen in this circumstance. So I just hope as we move forward, we can make sure all our ducks are lined up before we send it off. Thank you.
All right, thank you, Representative Liebling. And with that, I don't see any other questions regarding the bill. Ms. Wingert, do you have anything other that you'd like to add to that?
We would appreciate support of this bill. We believe it is a bill that's time has come, and we think it is an opportunity for us to bring more children out of the biggest institution, that being the hospital, and put them in a family environment with a daycare center that is like almost every other family uses on a regular basis. Thank you for your consideration.
Thank you, Ms. Wingert, and thank you for the good work that you're doing with that. House File 3139, as amended, is laid over. Next up, we are going to do House File 3734, Representative Nels Pearson. Representative Pearson moves House File 3734 to be laid over. Representative Pearson.
Thank you for moving my
Welcome to the
bill,
committee.
Mr. Chair.
Please introduce yourself for the record and proceed.
Thank you, Mr. Chair. My name's Nels Pearson, Representative Nels Pearson. Is that what you're asking for? Probably not. House File 3734 is dealing with the Project Legacy in Homestead County. Project Legacy works with low-income youth of color who are extremely high risk and are not otherwise served by existing community organizations and charities in Rochester. The project is structured around the continued growth and sustainability of 5 distinct program areas. Project Legacy has developed these areas over the last 8 years, and they include Operation Outreach, Pathways to College, Operation Nourish, Operation Encourage, and Chemical Dependency. And in recognition of the shortness of time, I would like to just turn it over to my testifiers, if I may, Mr. Chair.
Thank you, Representative. Welcome to the committee. Please introduce yourself and proceed.
Thank you. My name is Karen Edmonds. I live in Rochester, Minnesota. My husband, John, and I are the co-founders of Project Legacy. Project Legacy was founded about 10 years ago as a program to provide opportunities and support to youth of color living in generational poverty or from gang-affiliated families or who are refugees. We have evolved from a simple program serving a handful of youth to what is today one of the largest programs in Rochester, serving a population that is unserved by other programs. We are now a member of the Global Homeboy Network, which is a part of Homeboy Industries, the world's largest gang rehabilitation program in the world, located in Los Angeles. We partner with Olmsted County Social Services, Workforce Development, Community Corrections, and the business community to provide intensive, long-term support to youth and young adults who are looking for an exit ramp from the streets and poverty. This year, we are supporting over 30 youth who are now in colleges or technical schools. We provide outreach and resource to 70 others. Those supports include educational assistance, food, shelter, and clothing, and connecting our youth to, and sometimes paying for, medical and dental care and chemical dependency counseling. Untreated trauma is addressed through group therapy that, or as we call it, healing circles, that are co-facilitated by volunteers who are also Mayo doctors and social workers. We assist youth in becoming drug-free. Our youth are oftentimes the collateral damage of drug-addicted parents. In fact, 80% of our youth have parents who have active addictions. Our youth have experienced the crack epidemics and opioid crisis firsthand. 75% have been homeless. 60% were in the child protection system at some point in their lives. Today, they are in recovery, in college, and working. We cannot afford to leave any of our children behind. They deserve the same opportunities that we were provided as children.
they are worth our investment. We can either ignore these children and claim they aren't our problem, that we have other projects to fund, and then pay over $40,000 a year to incarcerate them in Minnesota, and continue the cycle of generational abuse, neglect, addiction, and poverty. Or we can fund this program for an average of $4,000 a year per child to provide the supports they need to heal and graduate from high school and higher education and become happy, healthy, and contributing members of our community. I'd like to introduce one of our program participants, Dennis Paul.
Welcome to the committee, Mr. Paul. Please introduce yourself for the record and proceed.
Hi, my name is Dennis Paul. I'm from Rochester, Minnesota. I would like to start off by thanking you guys for letting me come up here today and speak with you all. So, when I was a kid, about 2 years old, my parents emigrated me and my 4 siblings out to the U.S. for better education, better life, and a better opportunity to access a better future. They're wonderful, loving people, and they provided me with a roof over my head for 17 plus years, food, and ample support. With all that, though, I had little guidance when it came to school. And after high school graduation, little turned to none. I had no help applying for schools, loans, financial aid. We just didn't know how and where to start. The school system that they were familiar with was very different from the one that we were dealing with now. So my plan was I took a year off after graduating to work and hopefully afford schooling. My first semester went well, education-wise, but all the work that I did, I was still in debt when I got out. And so I left school my second semester to work and pay my debt and then go back to school. And I was prepared to do that again and again if that's what it took. After a long day at work, though, one night I went to sleep thinking, this is going to take forever. This is hopeless. And I only regained my hope when I met Karen and my Project Legacy family. They helped me pay my outstanding debt, and for that, I promised her a 4.0 GPA. They helped me understand loans, financial aid, and scholarships, and now I'm receiving financial aid. I just earned 2 scholarships, and they provided me with mentors in my field of study to study, give me advice, and plan my journey. And as we speak right now, I'm on that journey. My end goal is to help people in the world. My other end goal is to achieve my dreams and become an anesthesiologist. I plan on using one goal to achieve the other, and hopefully help you guys, or help other people like you guys are helping other people. I'd like to thank you all again for letting me come up here today and speak with you all.
Thank you for your testimony. We appreciate it. Is there anyone else who'd like to testify in this bill? Seeing none, we'll close the testimony portion. Open it up to any questions. Seeing none, Representative Pearson, final word.
Thank you, Mr. Chair.
All right. With that, House File 3734 is laid over, and we are in recess to the call of the chair. Approximately 6:30 p.m. There you go.